Intubating a patient with a C-spine injury can be a really daunting experience for many clinicians. Until now, there has been very little guidance to support clinical decision-making and airway management in these patients. Today, I'm joined by Matt Wiles, Helen Iliff, and Kareem Elbogdadley to discuss the multi-society guidelines on tracheal intubation in patients with suspected C-spine injury. My name is Marianne Turner, and I'm an editor at Anaesthesia. I'm recording this podcast from the unceded lands of the Wurundjeri people of the Kulin Nation. I acknowledge their elders past and present, and I extend that respect to our Aboriginal and Torres Strait Islander listeners. I'm really excited to be joined by everyone today, and I'm going to invite each of our speakers to introduce themselves and tell us a little bit about their clinical background, as well as their involvement in the development of this guideline. Helen, can I start with you?
Thanks, Marianne. I'm Helen. I'm an anaesthetic trainee in South Wales, and I've been involved in the systematic review and the recommendations part of the guidelines.
Hi, morning, Marianne. I'm Matt Wiles. I'm a consultant anaesthetist based in Sheffield in the UK. My major clinical interest in neuroanaesthesia, and I'm also one of the major trauma consultants at my institution. So this has been an area of interest of mine for some time, particularly because it's always felt like a very grey area that causes a lot of consternation and concern amongst clinicians about the best or the right thing to do. So I conceived the idea of this to try and provide some clarity for clinical practice.
Hi, I'm Kareem. I'm an anaesthetist in London, and I've got an interest in various bits and bobs, including airway management. I'm the scientific officer for the Difficult Airway Society, or DAS, which is one of the reasons why I got involved in this work with Matt. And my role in the guidelines has been to help develop the methodology, deliver the methodology, and also contribute to, of course, the systematic review and the recommendations throughout, and hopefully work with Matt Wiles and Helen Iliff and the rest of the team to come up with some really good, effective guidelines for people to use.
Now, this has been a huge collaboration. You've got the Difficult Airway Society, the Association of Anaesthetists, the British Society of Orthopaedic Anaesthetists, the Intensive Care Society, Neuroanaesthesia and Critical Care Society, and the Faculty of Pre-Hospital Care, as well as the Royal College of Emergency Medicine. As someone who's previously been involved with multidisciplinary guideline development groups, like this is, how did you do it? How did you manage to get all of these diverse stakeholders in the same room and on the same page to produce this guideline?
Well, firstly, it does help that the room is virtual, because if it wasn't virtual and it was in real life, it would have been very, very difficult to get everyone in the same place at the same time. So that definitely helped. I think the first thing was to find the right stakeholders. And the right stakeholders doesn't just mean societies, but it also means individuals. So we needed to have the voice of anaesthetists, the voice of surgeons, intensivists, ED physicians, but also trainees, and really importantly is patient voice. So we had to find the right stakeholders, and when we found the right stakeholders and obviously their supporting organizations, it was about speaking to the organizations and getting them to understand what the gap in clinical practice is and how this can help support their clinicians or their stakeholders to deliver the best quality of care. I think it was very clear to everyone that we had to work together on this, and given the gap in the literature and the gap in the practice, it was very easy to convince people to sit around the table. But then the next step was also to agree the methodology. So it's one thing to say, right, guys, let's all come in and let's write some guidelines. But it's very easy with so many different opinions for you to never actually get any consensus or agreement. So once you've located and determined who the stakeholders are, the next thing is to make sure that everyone agrees and signs on to the methodology. Because once you sign on to the methodology, which I think we'll talk about probably in a minute, of using a systematic review to find the best evidence and using Delphi methodology to design, refine, and improve the recommendations, what that does is that takes it away from an individual's opinion and brings it to the multidisciplinary group and evidence-based decision-making to formulate the recommendations. So finding the stakeholders and making sure it's as multidisciplinary as possible and agreeing the methodology so that we can proceed without everyone trying to enforce their own opinions and over anyone else's.
Now, getting the right methodology for any sort of research project is obviously very, very important. Matt, can you sort of walk us through the process behind that and how you went about developing this methodology?
Yeah, absolutely. This is something we're taking on at Anesthesia. So I'm going to self-cite my own journal because that's what the editor-in-chief does. And we've recently produced our own recommendations to try and advise other groups when you set about this process, because it is daunting. And the key part of this is getting it right at the start. So you need to, the idea starts, but then you need to get the right people, as Karima said, all relevant stakeholders. And I think the one that I particularly wanted to make sure there was a voice of was the trainee voice, because actually the majority of these patients aren't dealt with by consultants. We're generally safe at home in bed when the sun goes down. And it's the trainee who's presented with this very difficult case in the middle of the night and probably intoxicated and not knowing what to do. So it was very important that we had guidelines that were based upon actual clinical practice by the people delivering it. And then there's the confusion about what is a guideline, what is a recommendation, what is a consensus statement, what is a advisory practice principle. And there's a paper within the journal that helps elucidate this. But for us, this was obviously an area of clinical importance, but also with the spectre of medical legal problems, which is often a big driver and a big concern for clinicians doing this. So we went along the most formal route for this, which was a systematic review, which Helen and Karim led with expertly, a synthesis of the evidence, then managing to take some key recommendations from the available evidence, presenting it to the group, this multidisciplinary stakeholder group, and then the key element then is to have some measure of agreement. And in this case, we used the Delphi process with predefined levels of what we felt agreement would be to come up with the finished document. And then also to use grade recommendations for the strength of the evidence we have. The whole point being that what you want clinicians to have when they read it is to see that a synthesis of the available literature has been made. The stakeholders have considered it and they've agreed as a group en masse. So we're not saying the ICS is different from the Royal College for Emergency Medicine or the Association of Anaesthetists. And then there's a strength of recommendation, which we'll probably come to a bit later. But it also lets the readers and the clinicians know how confident we are and the level of evidence that supports practice recommendations.
And I understand, Helen, that you spent many, many hours trawling through all of the literature and desperately engrossed in reading all of the studies that have led to informing this guideline. Can you tell us a bit about sort of why these guidelines were developed and what clinical need they were addressing?
Yeah, of course. So I think, a bit like Matt said and Karim said, that I think there's very little evidence out there for secondary spinal cord injury secondary to intubation. And I think there is a disproportionate amount, or there's definitely a huge amount of concern in people when you're intubating these patients, particularly as trainees overnight, don't have another pair of senior hands and stuff available. And even though less than 2% of trauma patients have a spinal cord injury, we know those that do have a spinal cord injury, it's nearly 45% of that cohort. So it is a significant amount. So the aim was to obviously try and synthesize data to try and come up with some practice recommendations. But the difficulty in that is that an awful lot of these studies are done in well patients with collars fitted, which isn't our cohort of patients. So to try and transfer that data across is very, very difficult.
I think the other thing to point out there about the evidence is there's a lot that, as with most research work, the devil is in the detail. And if exactly as Helen said, a lot of these are simulated in patients. So we make the airway difficult as if they were immobilized, or we even worse use mannequins, which we don't really need to manage at all ever. But then we look at the metrics people have used, and then people talk about spinal cord movement. And a lot of these are lateral radiographs looking at column angulation. And that's not actually what matters. What we're interested here is the risk of spinal cord injury, secondary spinal cord injury. And obviously the neck and the cervical spine and the cord itself is a three-dimensional structure. And the best studies look at the space available for cord. So actually the space within the vertebral canal that it lives in, and the impact of maneuvers on that space, because that probably gives you the best idea of the risk of impingement. Very few studies have done that. So it does leave us with this problem, and people will often, I've often spoken about cervical spine immobilization, other things before, and people cite papers back. And I've said, but this is just an external measure of a few degrees. What is clinical significance? And we don't know. We also have an aging population who, and a lot of our trauma now in the UK, 50% will be aged over 50 or 60. And they're another under-researched group, particularly in the historical studies, in terms of looking at patients who already have cervical spine disease, osteophytes, and the impact upon them. So I was quite surprised, actually, by how little good quality evidence there was, bearing in mind the strength of some of the statements in airway management that have been made historically in a lot of previous papers and in most anaesthetic textbooks.
And additionally to that, and what Matt was saying, even the cadaveric studies that they've included, they've got cervical ligamentous injuries that most of them would probably not even make it to your ED alive. A lot of the injuries that they're using in these cadavers are very little compatibility with life by the time they get to us. So it's difficult then to even take those ones. So it's very difficult to get an overall picture of what the impact is in these patients.
And I guess that what we saw was in the absence of good quality evidence, we need some form of at least semi-robust methodology to formulate recommendations. And I think that's where the Delphi process has its real strength. That's why it's really important to have a Delphi process there, because yes, you take what you can from the literature, and we knew that it was very poor, but we have methodology to agree a consensus. And I think that's part of the strength of what we did here, really.
And this was the thing with the paper, wasn't it? A lot of the recommendations that have been made are grade D recommendations. What does this mean? And should this level of evidence result in a change in clinical practice?
As I said, I think you have to be very honest about the evidence you find. And there are two things you take from this, is that actually a lot of the evidence in inverted commas underpinning a lot of dogmatic practice is weak and should be treated as such, and may be very difficult to extrapolate beyond a mannequin, beyond a cadaver, beyond a fit and well person having non-spinal surgery. So I think it gives, it almost waves a flag saying, actually, the evidence out there is weak. It would also hopefully serve as a bit of a call to arms to say, actually, this is an important population. The sequelae of getting this wrong is potentially great. So we probably do need some more higher quality research. It almost feels like because we've done things for so long one way, that's been set in stone and that we don't need to revisit things. But actually, practice has changed dramatically over the last decade. You know, if people say, what do you think of the changes that will happen in the next 10 years? I mean, I've been in anaesthetics for about 20 years. In my first 10 years of practice, the only thing that really changed was paracetamol started coming in a glass jar and etomidate disappeared. That was pretty much it. In the second 10 years, we've seen ultrasound-guided renal anaesthesia absolutely explode to levels we've never seen. We've got rates of TIVA, for a variety of reasons, also increasing incredibly dramatically, and the advent of video laryngoscopy. You know, if you say, where would we be in another 5 years? I'd say we'd probably be in a situation where direct laryngoscopy has been consigned to history and potentially volatile anaesthesia following it. So I think, you know, we are at the crest of a wave of some exciting and very different changes in practice. And we almost need to think about resetting the research agenda in light of that.
Now, I think we should put all of our readers, our listeners out of their state of suspense and actually tell them what changes these guidelines suggest, or what changes in practice do you think we're going to see after these guidelines have been distributed? Tell me, what should we be doing?
I think we should be doing I think the key takeaway is to do what you do well. And if you are comfortable and confident with doing awake tracheal intubation, then do awake tracheal intubation for airway management of these patients. If you're not, then you shouldn't. If you have access to video laryngoscopy and are trained to use it, then you should use a video laryngoscope. If not, then do what you do best. For me, that is really the key. I think the other thing is that there's obviously very good evidence for things like videolaryngoscopy. And the biggest change in practice, I think, will be to encourage more people to train and maintain their skills in videolaryngoscopy. We know that the more that you do, the better you're likely to be, and the more likely you are to be successful at first pass intubation without complications. And so for me, videolaryngoscopy is a really big one here. But until you're competent and comfortable and skilled with using a videolaryngoscope, do what you do well.
And that's a bit of a change, I suppose, from what people may have traditionally thought about how to approach intubation of a patient with a C-spine injury.
Yeah, I mean, particularly thinking about awake intubation, the evidence was obviously very poor. And one of our takeaways is there needs to be more data on awake intubation in this cohort of patients. We really, really need those evidence. Now, think about it. Traditionally, people used to say intubate awake so that we could show that the hands and legs are moving before you induce anesthesia. What happens if you've intubated and the hands and legs are not moving? Then what? Well, I mean, there's not much you could do about it at that point. When you're performing awake tracheal intubation, patients are coughing and spluttering sometimes. Unless you've got a system and you're able to do it with minimal patient coughing and bucking and all of this. If you can do that, then great. But if not, patients are all over the place sometimes. And if you're not comfortable with doing it, you're just going to make your airway much more difficult, and you may actually aggravate any potential cervical spine injury with a suboptimal awake intubation. So for me, the emphasis of they all have to have awake tracheal intubation is we need to be a little bit more balanced on that. If you are comfortable doing awake intubation and can do it well, do awake tracheal intubation. Sorry, Matt, you were going to come in on that.
No, I think that's absolutely right. I mean, there's no overwhelming evidence for one technique, and the recommendation for videolaryngoscopy was mainly based on other studies that basically show improved first pass success, which obviously the minimal you can move it, the cervical spine, the better. What's even more important is to avoid difficult, prolonged intubation, the risk of hypoxemia, the risk of hypercarbia in these patients, which is obviously, if there is a spinal cord injury, then that's going to make matters worse. So a lot of that has been extrapolated for success rates. However, I think I would want to emphasize that we're not saying that direct laryngoscopy or awake tracheal intubation is bad. We're not taking one dogma and swapping it for another one with video. It's exactly as Corinne said, whatever you do it well. And if you think in other spheres, we all have our areas and skills, and we have anesthetic A, B, and C, and sometimes even D. If you try to give somebody else's anesthetic, I've never had it go well once.
Yeah, it's so true.
If you try, I'll do this because of X, or this is I should try this, particularly those of us and when you anesthetize colleagues and other people, you think, oh, should I do this? And you realize, no, I should do exactly what I always do, because that's what I do every single day, and that's when we've got it. And that would be one of the things I would want people to take away, that their best technique is probably the one of choice, and also that tracheal intubation is very, very safe. One of the nicest studies we found in this was they looked at somatosensory evoked potentials, which is a really good measure of cord function with tracheal intubation. There was, in a smallish study, a couple of transient blips during tracheal intubation that settled rapidly. However, when they got a much, much, much higher rate of cord signal change during positioning. So the things people then see, the tube's in, oh, I can relax. That's not a problem. It's probably it's probably completely the wrong mantra. The tube's in, but now I still need to be careful. The American Closed Claims Database shows that most episodes of patients who develop a perioperative cervical spine injury were not having cervical spine surgery and were, in inverted commas, normal spines before, but poor positioning and other bits exacerbated probably a threatened cord. So yeah, I do a lot of trauma anesthesia. I probably worry more about the cervical spines in the elderly patient having their hemiarthroplasty on their side than I do about the young person who's gone through the windscreen of a motorbike, which seems a little bit odd, but I think that's where we're at.
I think
No,
additionally, for me, I think just as a trainee, there's a focus on doing simple things well. So try and decrease the amount of movement you have during pre-oxygenation and face mask. Use a supraglottic airway device that you're familiar with. Try and do a jaw thrust, not a head lift, chin lift. Use a device that you're used to, a VL, an awake, whatever, but use something you're used to. Have regular training, be that in a department. Think about using a bougie, take the collar off. If you're using Mills, take it off if it's difficult. So there's a lot of emphasis on doing simple things well.
Now, Helen, you've just mentioned Mills, and I was going to ask you about that. Is there still a role for Mills, and what should we all be doing about that?
So probably the most controversial recommendation in the guidelines is around Mills. There's, like we said about all of the evidence, there's very poor evidence for or against pretty much everything. And Mills is no exception to that. So our recommendations around Mills are, if you do choose to use it, if you encounter difficulty, get rid of it to try and improve your view. So I think it will be interesting to see how that's taken by the anaesthetic community, but it has been done on a very thorough process with consensus agreement from all the experts in the room. But yeah, I think that will be probably one of the more interesting recommendations to see people's opinions on.
Yeah, I think conversely, there's the strongest evidence for Mills is it will make tracheal intubation much, much harder. There is really good evidence for that. The evidence that it actually immobilizes any segments is very questionable, and actually, if not done correctly, can actually cause pivot points and cause more displacement. So this was discussed at length, as in, do you say Mills shouldn't be used ever? And I think a recommendation was softened to say it can be considered, but a bit like, and I think we made this maneuver some time ago when we think about cricoid force for rapid sequence intubation, particularly in obstetrics, is by all means start with it on, but don't let it make you struggle to do the right thing, which is to intubate your patient's trachea. So if you do start with it, that's okay. But hopefully these guidelines will mean that a trainee would feel confident to say, I'm really struggling, I've got no proper view, this is grade 3, grade 4, blood in the airway, take off the manual inline stabilization and just let me secure this patient's airway safely.
And I think the comparison with cricoid force is a really good one, because just out of interest, there's 4 of us here who would routinely use cricoid force in a rapid sequence induction. No. So none of us. But 20 years ago, when Matt was a good 20 years into his consultant career, possibly, it would have been completely crazy for us to say, no, don't use cricoid force, right? So had we made recommendations then to say, don't use cricoid force, everyone would have been up in arms. And I think that with Mills, we're kind of following a similar trajectory, but only a few years later than with cricoid force. That we're now saying the evidence demonstrates that it just makes intubation worse, and it doesn't reduce the risks of airway management in terms of on the cervical spine. Just as the evidence suggested that cricoid force made airway management more difficult, but didn't necessarily reduce the risk of pulmonary aspiration. Exact same thing. And there will be people that will think that this recommendation is not appropriate for their clinical practice, and that's absolutely fine. People should do what they're comfortable with. They're only recommendations. We're not enforcing anything. But really, when you look at the data, and maybe there is a scope for more data there, and maybe the people that really strongly believe that Mills is mandatory throughout airway management, we should be getting data from them. They should be doing the research, and I would really strongly encourage that. But, I think we've got to be pragmatic rather than dogmatic here.
I think one of the recurrent themes that I've heard from all of you is about the scarcity of evidence behind, sort of how we manage these patients. If you were in charge of the research agenda and had unlimited funding moving forward, what do you think, which areas should we be focusing on in order to ensure our patients are as safe as possible?
I'll start off. It's clear video laryngoscopy is here to stay. So we need to know the precise impact of this, but also we weren't able to make recommendations upon different types of video laryngoscopes or different types of blade. So I think that would probably be an area of interest, particularly the use of hyperacute VL in this patient cohort. In general, it would be interesting to do more high quality research looking at tracheal intubation, particularly in older patients, and actually what happens to the space available for cord during common movements, because the overwhelming evidence is that laryngoscopy is very, very, very safe. And some people with spinal cord injury do deteriorate afterwards, but that's a phenomenon even in patients with spinal cord injury whose tracheas were never intubated. It's just that anesthesia is often blamed. We get blamed for many things in our profession, don't we? And I think this is just one more of those. The other thing that would be really good would be a registry, because we don't really know our denominator. So actually, we have, for example, in Sheffield, we will deal with about 2,000 polytrauma patients, so ISS more than 15 per year, of whom a number will have their trachea intubated. I can't think of one who's had any forms of problems with late spinal cord injury, but we don't routinely collect those data. So if we did manage to collect a national database of doing this, I think with time we'd see our denominator is absolutely huge, and the numerator will be so small with such specific instances that we could probably make a lot of people a lot more relaxed coming to work and dealing with these patients. These are often high cognitive load cases, bleeding very unstable, and if these guidelines do anything, if it gives people a little bit of mind space that they can just focus on what they do well and then deal with all the other things we have to deal with as part of this, this would have been a worthwhile venture for us.
I think what Matt was saying about a registry would be like super helpful.
Yeah.
I think as well, I think in terms of quality of evidence, unless there's some very good RCTs and good meta-analyses done, I don't think we're really going to get very many answers quickly. I think this is a long-term gain. But I think that there will be difficulty for people who want to do studies, who want to try and get ethical approval, because that's why I think maybe some of the mannequin studies and the cadaveric studies are easier in a way, because the ethical approval side, it's very difficult to prove that you're not going to cause an injury versus that you are. So I think it's a difficult proposition for people who want to do the research, but it's not impossible. And I would very much encourage people to go out there and have a go and try, because there's definitely a space for good quality research in this area.
We've got 2 minutes left, so we're going to do take-home messages from the paper. I'm going to go around the room. You've got, I don't know, 10 seconds each. Matt, go.
Mills is my baby, so treat Mills with caution. Use it if you like, but don't imagine it's doing anything magic, and don't ever let it get in the way of a good intubation.
Kareem?
If you can, use video laryngoscopy if you're trained to do it. And if you're not trained to do it, then go and get trained to use video laryngoscopy, particularly for these patients.
And I've saved the best till last. Helen?
Do simple things well.
Perfect. Thank you all so much for your time. I'm so grateful. I know how busy you all are, and it's just congratulations on producing such a collaborative and comprehensive paper. I really look forward to seeing how it is used in clinical practice. I'm sure it will be very popular. Thank you. I encourage all of our listeners to get on board, listen to the podcast, have a look at the paper, and obviously jump on Twitter. Oh, there's a QR code that you can scan there as well to access the paper, and jump on Twitter to participate in the discussion. We're always interested in all of our readers' feedback. Write us some correspondence or get involved with the discussion online. Thanks again, everyone. I'm so grateful for your time.